Hi guys, we're going to talk about chapter 32, and this is looking at health assessment of children. And we know assessment involves many components. It involves the health history, observation of the parent-child and those interactions, assessment of the child's emotional, psychological, cognitive, and social development, and then actually doing that physical assessment. So let's get started here. As we dive into the health assessment, nurses need to obtain detailed information that can be acquired by asking about the demographics, their chief complaint, past health history, reviewing each of the systems, talking about family health history, developmental history, functional history, and really looking into that family composition. What resources do they have available for themselves? What does their home environment look like? And then really, again, observing that parent and child interaction. And we're going to talk about each of these a little bit in more detail as we move through this chapter. So as we look at the role of the nurse when they're performing that physical assessment of a child, we really need to establish that rapport, that trust, kind of get down on their level so that they will talk to us, so they will play with us. We really need to demonstrate respect for the child and the parent or the caregiver. We have to approach each of the children differently, and it's really going to be based off that developmental level that they're at. So approaching them appropriately developmentally. We want to communicate effectively by making sure that we're actively listening, we're leaning in, we're making good eye contact, and we're demonstrating that empathy, and then providing any feedback that the parent may need immediately. We also want to come up with a systematic examination approach so that we make sure we don't miss anything. And then we want to make sure we're able to validate and interpret any data that we get so that it is accurately charted or documented in their chart. So we hit on this a little bit in chapter 31, but just as a refresher, how do we explore the family dynamics during that health history? This can be done with lots of observation. Does that parent make good eye contact with the infant? When the infant cries, how does that parent respond? Does that parent anticipate and respond to those needs? Are the parents ineffective when dealing with a toddler's temper tantrum? So we know that temper tantrums are typical ways for toddlers to deal with struggles that they just don't know how to handle. So how are the parents effectively or ineffectively dealing with those? Are they giving simple choices? Are they using distraction? Are they calm and positive, maybe not giving in to some of that temper tantrum? Do the parents comments increase the school-age child's sense of worth? So are they really critical of their abilities? Are they comparing them to siblings? Are they harping about their mistakes, never praising them? And then behavioral observations are crucial to proper assessment of those family needs. And you're going to see those either non-verbally or verbally as you observe. A thorough and thoughtful assessment of a child is the foundation upon which the nurse determines the needs. If nurses are not thorough, needs can fall through the cracks and healthy goals may not be achieved. So let's talk about the characteristics of a chief complaint. We really want to ask that parent, what is the chief complaint? Or what brings you in today? Today being that key word. If you're not specific, you may get the entire health history of the child when really all you're wanting is what brought them in for the day. What was the onset, the duration, any characteristics and course? So again, that's that today, not your whole life story. Previous episodes in the child or the family. So has this happened before? Were there any changes in the environment or daily routine? So if we're talking about anxiety, if we're talking about a rash, maybe an allergic reaction, were there any changes? Has there been any previous testing or therapies done? What makes it better or worse? And have they done anything to make it better, or did they do something and it made it worse? What is the concern? Means that for the child and the family. Remember, when we're taking care of pediatric patients, we're not only taking care of that patient, the whole family becomes part of our dynamic. And then we want to inquire about any exposures to any infectious diseases. So aspects of the past health history. So as we're looking at that past health history, what is some information we would like to have? Was there any prenatal or perinatal history? Any past illnesses or other developmental problems? Any prior history of illnesses, accidents, or injuries that happened in the past? Any operations or hospitalizations that the child may have had? What's the child's diet? And do they have any allergies? Is our child, our patient, on a specific diet and why? And if there are allergies, what type of reactions did they have? What did they see? How did the child feel? We also want to get an immunization status, if they're current, if they're behind, and then kind of talk about why they might be behind if they are. Any medications the child might be taking, and that's going to include any over-the-counter medications or prescriptive medications. And for our females, is there any menstrual history? So as we're looking to obtain that family history, because that's another part of the health interview, we want to ask about 3 generations of that family history. This is really going to help us identify those trends and those specific health issues. And this diagram here on this slide just gives you that 3 generational genogram so that you can see those trends, see those special health histories that might be going on. So when we think about review systems systematically from head to toe, making sure that we're inquiring about current or past information of problems related to each of these things that are listed here. Table 32.1 on page 1121 has some really great questions that are very specific to each of these systems. When we are looking at the developmental history, there are some considerations we need to look at. The first one is how to approach that child developmentally. Infants and toddlers, we're going to examine them either in a parent's lap or that caretaker's lap. Preschoolers may want to inspect the equipment. Let them handle that stethoscope or that blood pressure cuff. It's, again, you're building that rapport, that trust, and they're becoming more familiar with some of those things that might be scary to them. With our school-age children, we want to involve them as the patient. Let them have a little bit of sense of control, right? When we go into that hospital setting, even as adults, we lose a lot of control. So really kind of giving back some of that control to that school age is going to help with that cooperation. And then our teenage groups are really going to provide or prefer that privacy. When we're conversing with our pediatric patients during the exam, some considerations that we might think about are engaging that infant, that young child, as needed for distraction. Talk to or with the caregiver for the young child. If you're with an older child, a teenager, make sure you're directly talking to them, that you're considering them into that conversation. So how do we prepare for each age group for the physical examination? When we look at the newborns and infants, we can ask the caregiver to hold the baby or make sure that baby is within the view of the caregiver. Stranger anxiety is a normal part of development in this newborn and infant stage. And if the parent's not holding, we want to make sure that the baby can at least see them. And that's going to help alleviate some of that anxiety. We want to auscultate heart, lungs, abdomen while they're sleeping or while they're quiet. Remembering that the heart rate is really fast. They are diaphragmatic breathers, so we're watching that belly. And if you can do that while they're quiet, it's going to be a lot easier to hear. We're going to count the heart rate, the respiratory rate before we undress the baby. When we start getting those clothes off, we start agitating that baby, they're no longer going to be quiet for us. And then making sure we do that head to toe assessment, leaving the most traumatic procedures, meaning for this group, they're looking at their ears, their nose, their mouth, their eyes, leaving that kind of for the last thing to do. Toddlers can be very challenging to incorporate So incorporating play into the examination may help with that cooperation. This play may include letting the toddler handle the equipment so that it is less scary. Allowing that toddler to be held will also alleviate some of their anxiety. Make sure you praise the toddler when they do things that they are asked to do. And we have to remember that toddlers are very egocentric. So telling them how well another child behaved isn't really going to gain any trust or cooperation from them. The preschooler may fear body invasion and mutilation and will withdraw from any procedure or assessment viewed as intrusive. They want a sense of initiative that's going to lead to that cooperation. Preschoolers like to play games. And if you're thinking about taking a deep breath, so if we want to encourage that deep breathing during that auscultation point, maybe holding up a finger, holding up your pen light, pretending there's a candle, and instructing that child to blow it out is going to give them that play per se, but it's also going to help with your assessment findings. The school-age child's thinking is very concrete, but can be objective and realistic. We want to avoid using any medical jargon or words with any double meaning. The school-age child is interested in how things work and why certain things need to be done, and they're going to be more responsive to truthful and simple explanations. So describing and commenting on your findings during the physical examination is interesting to that school-age child. And then we always need to remember to respect the child's desire to avoid any pain or any insult. Attitude of respect from the nurse will go a long way with the teenage group. Speak to that teenager using mature language, help appeal their desire to promote self-care. We want to perform the assessment in a head-to-toe manner and only expose those areas that need to be examined. And then really allow that teenager the opportunity to ask any questions they may have. The physical examination should include some measurements, determinations, and examinations. Measurements are going to include weight, length or height, head circumference, and your vital signs. And that's going to help determine our body mass index. As we do our physical examination, we're also going to get that general appearance. This is that first impression. Does that child appear sick or are they well? You can observe their alertness, their energy level, even their attention span. As nurses, we need to develop a very consistent pattern to examine our patients so that we don't miss any systems along the way. The order of physical examination steps should be observation, palpation, percussion, and auscultation. So just remembering those steps and how the order that you go in. With observation, we're looking. This may include that general appearance that we talked about. After observation, we're going to do some palpation. This is going to validate what we have observed. After palpation is percussion. Percussion is a useful tool for determining the location, the size, and density of our organs or our masses. A lot of times that's not a nurse's responsibility. That's going to be more on that provider, but just knowing that percussion has to come in that order. And then auscultation is that last and final step. Vital signs should be considered for any child with their physical examination. So when we think about vital signs, we're thinking about temperature, heart rate, respiratory rate, oxygen saturation, blood pressure, and then pain. Temperature, we want to use that same route for consistency. So if we're measuring that temperature tympanically, temporally, orally, axillary, rectally, that's the consistent way we want to do it every single time. When we think about taking our temperature, we want to think about that least invasive and accepted by the child and parent. Heart rate for the child should be attained when the child is resting or sleeping. For children younger than the age of 10, we're going to auscultate that apical pulse for a full minute. We're going to note any irregularities in strength or in rhythm. For our respiratory rate, we want to count that for that full minute because the rate is so irregular. Oxygen saturation is going to monitor that oxygenation in the blood by using a sensor that measures the absorption of light waves as the blood passes through a highly perfused area. Blood pressure is really recommended to do after the age of 3, and we want to make sure that we have an appropriate sized cuff. That's going to be vital. Cuffs that are too large or too small are going to give us those false readings. And then pain is considered that 5th vital sign. We're going to talk quite a bit about pain scales in chapter 36, but I just want you to be aware that that is part of a child's vital sign. Height, weight, head circumference, and body mass index should also be considered measurements during our physical examination, and we want to make sure those measurements are all within range. So this slide here just shows you the heart rate and respiratory rates for your kiddos, and you can see as adults, our heart rate's much slower, our respiratory rate is much slower. So remembering that when you take these vital signs in your clinical setting, that you want to count it for a full minute, because they do have some irregularities in that early stage where you're going to get some variation, unlike an adult who has a very regular heart rate and respiratory rate. This slide just shows you again a little bit more about that blood pressure and the locations that you can take it on a child. So thinking about that upper arm, that lower arm with that radial arterial artery, then you can also think about the upper leg and the lower leg. And again, making sure that the cuff size is an appropriate size. And again, you're also going to want to use the same limb every time. So if you're using that left lower leg to take a blood pressure cuff, that's where you want to take that each time for consistency. These are a couple of pain scales that you're going to see. And again, we're going to talk about this in more detail in chapter 36. But again, remembering this is your 5th vital sign. These 2 pain scales are your faces and then your FLAC, which we'll talk a little bit more about. So let's just really briefly talk about each of the systems that we're going to assess. As far as the skin, we're going to do inspection and palpation. So again, remembering that's that observation, and then we're going to palpate. So we're looking at the color, we're looking at the temperature. Do they have any lanugo? So that's that really soft, downy hair that infants can have. Are there any nevi or any lesions, rashes, lacerations, abrasions, burns, or bruising? After we've done our inspection, then we're going to think about that palpation. We're going to touch our infant, usually with the back of the hand, to check for that temperature. Moisture is a good indicator of hydration. Texture of the skin, and do you see any edema? Something to note, if there's petechiae or ecchymosis, this could be found over areas that were traumatized either at the birthing process, and it may take a few weeks to resolve. Certain cultures may use cupping or coining when a child is ill, and you may see these practices yield either bruises or mild burns. So if you're seeing that, it's just something you want to investigate. This chart here is in your book on page 1135, and it's just showing those variations in skin color. Pallor being kind of that pale, ashy gray color. Central cyanosis is usually that, it's just as it is, that central blueness of the lips, the tongue, the mucous membranes. Sometimes that can be a circulatory issue. Overall yellow color is jaundice. The yellowing of the palms and the soles of the feet may be just because they're eating lots of yellow vegetables. Redness of the skin from either blushing, exposure to cold, hyperthermia, just making sure that you understand where that redness is coming from. And then any lack of color can be related to that albinism. So as we look at hair and nails, we want to look at the distribution, the color, texture, amount, and quality of the hair. And then our nails, what's the color, shape, and condition? If the kiddos have really dry, brittle nails, that means they may have some nutritional deficiencies. And are there any infections around the nail? Are they nail biters? Are they cuticle biters? Do they have infectious processes that are going on that we need to look at? So when we talk about the head and the face and examining that, we're going to inspect it first for shape and symmetry. And then the biggest thing that we want to make sure we're palpating are those fontanelles. So fontanelles are those soft areas on the skull that remain open in the infancy to allow for that rapid brain growth. There's an anterior fontanelle and a posterior fontanelle. The anterior fontanelle closes between 9 and 18 months, where that posterior fontanelle is going to close between birth and 2 months. So when you're at Children's, I really encourage you, if you find an infant, to feel that fontanelle so you just have an idea of what you're trying to feel for. Fontanelles should not be depressed or bulging. Depressed could indicate some type of dehydration is going on. Bulging could indicate some type of increased intracranial pressure. So when we think about the neck, we're going to inspect that neck for symmetry, flexibility, and see if they have any pain with mobility. So if we're doing range of motion exercises where we're having them turn their head, do they have any pain with mobility in their neck? We also want to make sure we're palpating for any masses or lymph nodes. If you have any concerns with trauma in the neck area, the cervical spine must be maintained completely immobile until a radiologist has determined that the spinal cord has not been damaged. So when we look at the eyes, we want to look at external structures and internal structures. So those external structures that we're going to really note is the symmetry and spacing between the eyes. Do they have an even distribution of eyelashes and eyelids? Those epicanthal fields, perla, so we're going to shine that light. Does it react? Does it constrict? And then the muscle strength. Again, so that's that focused. Are they able to follow that type of thing? The internal structures are usually that advanced practitioner. So the glow of the pupil, optic discs, absence of pupillary reflex action that happens after 3 weeks may indicate some type of blindness. So it's nothing that you as a nurse will be looking at, just being aware that those are some of the things that they are looking for when they do the examination on the eyes. So ears also is the same concept, has that external structure and those internal structures. So when we're looking at external, where's the placement on the head? That lower ears from the eyes could be considered some type of developmental delay. Are they protruding from the head, or are they flat up against the head? Do you see any drainage? And then we're looking at that drainage, odor, color, consistency, things like that. The internal structures are, again, by that advanced practitioner. They may use a tympanometer, and that's just a wavelength that detects the mobility of the eardrum. It's going to tell a lot about, is there fluid behind that eardrum that may be causing some issues? And then definitely using that otoscope to look at those internal structures. Nose and sinuses, just looking at displacement. Is there unobstructed airflow? Assess any drainage that might be coming out. What's the color, amount, thickness, and odor? And then nasal mucosa. So that's shining a pen light up into that nose. Is that mucosa firm, pink, and free from any edema? When we're thinking about the mouth and the throat, we're going to inspect the mouth, again looking for color and symmetry. Is the mouth pink? Is it nice and wet and moist, which is indicating good hydration? Or is it taggy, sticky? That might indicate some dehydration. And then we're going to look at those teeth, maybe count those teeth, and do we see any dental caries, kind of that gray to black color to those teeth. When we're inspecting the throat, we're looking for those tonsils, uvula, and oropharynx. Thorax and lungs. So this is our chest wall, shape and contour. So you can have those concaved in, which may indicate that they need some type of surgical treatment. So looking at that shape and that contour. You can also look at work of breathing when you're looking at that chest. And when I say work of breathing, are they laboring to breathe? Are they using accessory muscles? Are they having some of those retractions? And this diagram here shows where you may see those retractions. So just be aware, subcostal's right below that rib cage. Substernal is that below the sternum. Intercostal is going to be between those rib cages. Suprasternal is above the sternum, and supraclavicular is right above that clavicle. So you would want to document, are they having retractions? Where are they having retractions? And is it mild, moderate, or severe retractions? And then we're going to listen to our lungs. We're going to listen to those breath sounds. They should be clear. If they're not clear, what sounds are we hearing? And that's going to indicate if we're having an upper or lower airway problem. So when we're thinking about evaluating those respirations in children, again, we want to observe the rate and the respiratory effort. Is it easy or is it labored? If it's labored, we're thinking about those retractions. If they do have retractions, we're noting those. And then where is those accessory muscles being used? We're going to listen for any unusual sounds, remembering that normal is clear, but if we hear wheezing, stridor, or crackles, we want to investigate further. And if they do have a cough, making sure that we're describing that cough. Is it dry? Is it hacky? Is it wet? Is it productive? Heart and peripheral perfusion. So when we're thinking about first our inspection, right, because that's the first thing, we're going to note, we're going to look, we're going to observe, right? What, do they have any pallor? Do they have any cyanosis, mottling, or edema? Do they have any clubbing of their fingertips? So clubbing might be an indication of just long-term chronic hypoxemia. Do they have any distension in those neck veins? Then we're going to palpate. We're going to palpate the apical pulse, that upper and lower extremity pulses, left and right. What we're looking for is symmetry. Does their radial pulse or brachial pulse on the left match the right? What's the strength? What's the quality? And then we're also looking at capillary refill. That again could indicate hydration status. And then we're going to auscultate. We're going to listen to that heart. We're going to listen for any irregularities. Do they have any murmurs present? So when we think about heart murmurs in children, this is a very common finding, especially in that newborn. A lot of times you'll hear that murmur in the newborn. By the time they come back in for 2 months, it's kind of resolved itself. We're going to grade our murmurs based on intensity and loudness. We want to note where that murmur is located, and if that murmur is radiating to a different location. And we'll talk quite a bit about murmurs when we get into our cardiac chapter. But this is just a quick, just be aware that there are 1 to 6 grades for that murmur, and really it's going to be based on that intensity and the loudness as to how it's graded. All right, as we keep moving down to that abdomen, we're going to observe size, shape, and symmetry. We're going to look at that umbilicus. Is there color, bleeding, odor, or drainage? So remembering when we have our infants and they have that kind of extra piece that's coming out, that's when we're talking about bleeding, drainage, odor, making sure there's not any infection going on there. We're going to auscultate all 4 quadrants of our belly, and we're listening for those bowel sounds. Are they normoactive, hyperactive, or hypoactive? If they're normoactive, you'll hear that growling sound, that gurgling, that clicking sound. In order to be an absent bowel sound, you have to listen for at least 5 minutes, and if you don't hear any of that, then you can consider it absent. And then we're going to also palpate those 4 quadrants and do light to deep. So if you'll see on this abdomen here, right, we're a little bit out of order. The abdomen is the only one where you want to auscultate before you palpate. Once you palpate, you get things stirred, you get things moving, it's going to change your auscultation examination. So making sure you auscultate before you palpate. Gastrointestinal and genitourinary. When we're touching the belly, we're observing the belly, that gastrointestinal, just making sure that we're avoiding any tickling when we palpate. For our urinary system, making sure that we're noting any hygiene. For For girls, do they have any labial adhesions? For boys, you could have, if it's an uncircumcised boy, making sure they don't have any adhesions as well, but also making sure that both of those testes have descended down. Musculoskeletal and neurological. Musculoskeletal, we're just looking at full range of motion of all of our extremities, and do those range of motions move symmetrical. Neurological, I think the biggest thing is just those reflexes. If you have the opportunity to kind of practice some of those reflexes with your kiddos at Children's, I would definitely take advantage of it. You're probably not going to see the nurse do it very often unless there's concern for it. Tanner staging is just that pre-pubertal development. It's a scale that goes from 1 till 5. For girls, this is when breasts start developing, they start getting some pubic hair distribution, so they're going to increase their Tanner stage. For boys, again, it's that pubic hair, scrotum size, and penis length. And again, staging 1 to 5. For breast, typically this isn't something the nurse is really going to observe. If you're a male nurse, I would probably bring a female in. But making sure that you're just looking for position, shape, size. Nipples should be located between that 4th and 5th rib. Some breast development can begin as early as 8, usually starts around the age of 13. If they have any tenderness under the nipple, that can indicate some pubertal changes. Sometimes you'll have parents call in with their brand new baby, that they're feeling some lumps underneath their nipple area, and that's just hormonal changes. And that concludes chapter 32 on health assessment. If you have any questions, you can shoot me an email. Otherwise, we can chat about it in class. Thanks, guys.